All right, so let's go to the first slide if we can. Let me see if I can remember how to do this. All right. So we're just going to talk about the fundamentals of the test itself, just the basic process, how they came about this particular test. Let me get my stuff out of my way. I don't like looking at myself anyway. Okay, so here's what the opinion is of APA College. They say these measures are didactic knowledge. This measures simple didactic knowledge associated with the safe and effective practice of psychology involving prescribing of psychotropic medications or collaborating with those who prescribe such medications. Now, many of you, I suspect, if you're clinicians and you're seeing a lot of patients, you are often asked to give opinions about medications because family practice docs, as good as they are, and their earnest effort to try to help a patient sometimes needs additional service. It's not uncommon for psychologists to make recommendations, and I'm beginning to, it's odd nowadays, I get social workers talking to their patients and having them come to me with the social worker's recommendation about a medication. It's kind of funny now that's happening for me. Funny in a way that it's kind of reversed. Most of you are doing that, correct? You're advising somebody about medications. You feel a little comfortable about the antidepressants. Maybe you're a little off-put by the complicated bipolar patients or schizophrenic patients, right? Yep, some people are saying that's what they're doing. Yep. That's pretty common. Everybody seems to be comfortable with the antidepressants because they seem to be a little cleaner, a little safer, that type of thing. Okay, great. But I know there's an organization that knocks the family practice docs, but I really don't, because they are, in a great sense, doing the best that they can possibly do. And when you get into this business, you're going to find the massive need. There are more patients than Carter has liver pills, okay, as we used to say in my neighborhood. You'll get more patients than you ever wanted in your life, actually, once you get into it. Who developed this? This is the APA College of Professional Psychology. There was an expert working group involved under the guidance of the Professional Examination Service. The members of the expert working group, I was in the original group for the purposes of making items that were associated with the neurological disorders and the neurotransmitters along those lines, neurochemistry. And I can tell you that most of the people in the room it was a diverse population. There were clearly PDP graduates. There was typically 3 of them there at a time. Everybody's familiar with the PDP graduates, right? Or you need a little history about that. Okay, Sean, you're not. All right, since one person admits they're not, then I'll tell you what they are. The Army and Navy and the Air Force made the decision to develop a program for psychologists to be able to prescribe through the Department of Defense. Senator Inouye of Hawaii was the principal architect of that, and eventually it morphed into different types of training. Initially, the thought was going to be that the person would be volunteers, so to speak. None of these people were really hand-picked. They volunteered to go through the program, and the program lasted roughly 10 years. In that period of time, they trained roughly, I think it was 10 clinicians, or they finally got 6 of them practicing as psychologists, prescribing in the military. The first iteration, the idea was you were going to go to, it was down in Texas, I believe, but it was, what do I want to say? Oh, a physician assistant training program. You would do 6 months of that, and then you would go up to a clinic or inpatient unit, psychiatric area, and learn inpatient practice and seeing more diverse patients. The program got stopped immediately by the American Psychiatric Association. They put up a big fight. Then they took the students that decided to stay. They moved them up to USA's Armed Forces Medical School in Bethesda, They had to take the first 2 years of basic medicine. They were told that their grades wouldn't count, and they were told that their grades would count, that type of thing. So you're taking people that may have not had a big chemistry background and throwing them into a biochem class in the middle of medical school. But somehow they were smart enough to pass, and they got by. There were a few that struggled, but as the program developed and became, every year it would be changed a little bit. There was a huge amount of money being invested in the evaluation of the program, and then what happened is that the Office of Accounting in the U.S. government delivered a report saying that this training was unnecessary because it was too costly, and it was costing roughly $600,000 to train one person to be able to prescribe outside of medical school. And that became a rallying flag for psychiatrists who were opposing this because they could say it was too costly. But what they actually did was they took these individuals and they told them essentially that they were going to assess their rate of fees as if they were a full-time medical student in the medical school, and therefore the costs they were levied at a much higher rate. And the students were not getting that type of service as they moved along. At the end of the day, they got these 10 people, I believe it was 10 that actually completed, I'm sorry, I think I said 6. But the total cost for each person was continued to be a big issue, even though the efficacy was well established thereafter. But what they ended up doing, and it was never finished, it was never fully developed, but what they finished with was 1 year of didactic training, and then 1 year of being on the wards. I think that's exactly what it ended up being. So it became a 2-year training program. Now, none of the civilian training programs are exactly like that. The civilian training programs have varied in terms of the amount of information you're supposed to get, but the categories have remained the same. And that's not changed over time. But the program in the Army, Navy, Air Force died. So they weren't training them. Now they're beginning to train them training some of these military officers now independently. These are all psychologists. If you are a psychologist and you have the ability to prescribe, they will allow you to come into the service and prescribe. So they're recognizing it, which is an interesting issue because here we have one branch, the military of the government, that allows you to prescribe within the context of their hospitals and the service of civilians, as well as civilians meaning spouses of military people, and yet the Medicare system denies us from prescribing medication. Not that they deny it, they say they won't pay for it, which is interesting. That's two separate branches in the federal government, and they're at odds with each other. And there has been some movement in the Indian reservations to get people to be able to prescribe, and I think that's gone fairly well. And now we're seeing some of alliance efforts at trying to move into these other types of countries that might be willing to do this. And one of them has been in South Africa. Now they're working in New Zealand, and that looks like it's going to happen in New Zealand sometime soon. So the more people that get into this, the easier it is going to be to get the proper training, the easier it's going to be to find more robust tests, because no one knows for certain that the PEP itself really says you're as good as they say. This is a theoretical test on many levels, but it is based on experts. So the questions were brought together. They worked through it statistically to come up with what they thought was the first generation of this test. Now there's a question that follows. How do you know that it really says what it's supposed to? It's just a content validity type test. And most tests, like the EPPP that we're all familiar with, are not tested against some empirical group. It's a theoretical test. It says this is what we, the experts who do this type of activity, believe that this is the type of knowledge you need to be able to demonstrate. And it's been defensible. You know, essentially it works relatively well as best we can tell, and it's the best we have. The reason you can't do a reference group is because when you first go out and take the PEP and you want to be able to prescribe, you're still at a point of developing your skills. You haven't yet honed your skills and become a more of an expert. Whereas psychiatry has a residency process where you're spending more time learning, more time demonstrating your skills, and then you move through this proper advancement. They have a nice sequence of advancement, and then they're all requested to go take their board. And in general, most of them pass without great difficulty, but their expert level is higher. So we use this, the test here is using the validated practice-based content outline. Psychologists, item writers were encouraged to draw upon actual treatment experience to ensure validity, fairness, relevancy, and clarity. There always are two formats. It has 150 multiple choice items. When we were originally writing the items, we had very specific standards that we had to follow. All the stems of an item, all the choices had to have the same essential lengths so that you wouldn't give away a particular item by having one being very short or one being very long. You were never to ask in the negative which of the following is not. It was always to do a positive affirmation type of test. There were a bunch of standards that we had to follow, and since then that sort of faded away. I think they've made some recent changes that might improve that, but they've drifted into doing what everybody does. Negatives, not being so careful with the stem length, those types of things. And there are two essential issues: recall of facts that you have to pay attention to, and then the analysis and judgment. And that's the way they like to mess you up. They give you a bunch of facts, and then you have to make a judgment, and you have to reason through those facts that you have. Sometimes they're red herrings. They're not important. Sometimes they're critical. And it's being able to tease out what's the pertinent fact to help you make a decision. You are given 3 hours to complete the test. It's always taken at Prometric these days. And we'll go back to that in a moment. This is the basic initial clinical content. And so you'll see these percentages are the number of items that they're supposed to have. Essentially 15% of the items should be reflecting this category: integrating clinical psychopharmacology with the practice of psychology. Neuroscience should be 8%. Nervous system pathology is 9%. Physiology and pathophysiology is 9%. Biopsychosocial and pharmacological assessment and monitoring is 10%. And differential diagnosis is 13%. And then you have pharmacology, that's 12%, clinical psychopharmacology, 13%, research 4%, and professional, legal, ethical, and interprofessional issues, 7%. So that's the content of the initial exams. Now they've made a change this year. Lucky you. They've made a change. They've added a category, and we'll get to that later today. And they've actually rearranged the percentages, because when they added an 11th category, that meant that they had to pull from the other categories to get some percentages. Because you have 150 questions and the categories are rather large, and you're going to see that in a little bit, you really have to get questions that overlap a little bit, that cover both one area. So you might have a question that has both pharmacology and clinical psychopharmacology within that question. That's the type of thing they would do to conserve the number of questions. Now, let me see, go a little further. It's revised every year. So every year you have 2 active form, 1 being revised. Every year one falls off the cliff. I'm not sure they completely lived up to that, but as best I can tell, they have. So you have 2 active forms. That becomes important if you fail. And I'll tell you in just a few moments why. Well, the obvious is that they don't want you to take the same test, okay? But there are other reasons too. 1 new form is added, and it's modified form, and it will be modified only by 30% of the items. So you'll get 30 new items in that particular test. So as one falls off and another one comes on, still having 2 active exams. One of them is going to be modified for the new information. The other side of that is that if the content changed, which it did this past year, they had to create 2 exams to start over again and then put one in hold. That's what they had to do, because they had to create the new items for the new parts so that it would be equally spread across both examinations. So the items are associated with changing knowledge. So when we know something more important, remember, more important, meaning that there's going to be some serious issue that makes this something we should put there. If there's another major study, you know, like a STAR-D study, what it said about the medications and psychotherapy and all of that, that's a big issue. That's going to be there. The Katie studies, all of those basic large-scale studies that say something important, you can bet you're going to get asked a question on those. And so you really do need to know those areas. And they also try to fix bad items that are potentially a good item, but there's something wrong with it. You know, it's something that gets missed in the printing or something in the editorial aspect of the test that gets to be a problem occasionally. And you have to have a way of revising those. So, what's the passing score? Anybody know? Nobody's raising their hand. Okay, 3 says 70%, and Heather says isn't 1. Peter says 70, 70, 70. Okay, as a rule, if you want to just have the simplest way to think about it, you want to be 71% plus, as a rule. However, since some of these exams are new, they may not, they go back and they go through a criteria reference methodology to make sure that the cutoff is accurate. And if they discover a bad item, they have to modify the percentage. So it's basically a criterion reference determination. So if you were to ask Jan Chucho, who's in charge of this up at the APA College, she would say there is no absolute cutoff. But if you really think about it, most studies say, most of the tests have always been around 70 to 71%, so you really want to be 71 just to be sure, okay? And the truth is this, what's a good passing score? A pass. That's a good passing score. You don't get more brownie points if you have a higher score. Now, some people like to brag, I got an 81% or I got a 95. It doesn't mean a thing. It doesn't mean you're a better clinician. Maybe you're a better test taker. It doesn't mean a whole lot beyond that, as long as you pass. That's the key. So there is no predetermined failure rate. You're going up against some reference that you should know this. And again, it's all about being safe. Are you safe? So items were always evaluated based on difficulty for the just good enough practitioner. Safe. Importance of safe and effective practice. Its recommended passing score represents the minimum level of knowledge to be safe and effective. So if you fail the exam, it's saying essentially you don't have the knowledge to be safe and effective. So it's not just arguing with the content, like people that when they take the EPPP, if you're a clinician, you tend to complain about the EPPP because they have all these IO questions, and if you're not a clinician, you tend to complain that they had all these clinical types of questions. If you're an industrial organizational psychologist. Either way, you got to pass the thing, and you can argue with the content all day long. It's not going to change anything. But in this case, it's actually meaningful knowledge is saying that you are not safe. You simply are not safe to do this. So that you should take that to heart, not dismiss it. When we finish this section at the end, there's a chart there that tells you the pass rate across the schools, and there's no. I haven't seen any new information on the pass rate for the new forms yet. I will try to get it from Jan as soon as I can, but other than that, I can't tell you really. If you said 70% is the pass rate, maybe you would think that 30% are failing, but I don't think that's necessarily true. So I don't know. In Louisiana, I do know that there have people that have failed. I'm not going to tell you about who these people are. In Louisiana, it's a really high-stake test because you're only offered it 3 times. If you fail it 3 times, you can never prescribe in Louisiana, ever. The medical board won't allow it. So there's a lot more pressure here. And I'm not sure what New Mexico's status is about all that. But in Louisiana, it's a high stakes. You're either going to pass it by the time you finish the 3rd one or you're out. So far, knock on wood, those that have passed buckled down, figured out what they needed to do, and passed. Psychologists are smart people. They just need to do the work, and there's more memorization to this type of work than we're accustomed to. Let's see. Each item receives equal weight, so one item's not more important. The passing is typically set at approximately 70%. Recommended for use by state and provincial psychology licensing authorities in awarding prescriptive authority. So every state, the 2, clearly use the PEP as a passing test. Now, our law, and probably in New Mexico, we had to have some alternative possible test, but this is the preferred thing. And the reason we did that is because you have to think in terms of what if APA decides not to do this anymore. Then we'd have to come up with our own kind of standard, our own test. So that's an issue. So we have to have that possibility to use something else. It's administered at through Prometrics. The computer knowledge is not required, but we all have at least rudimentary understanding of computers. Simple tutorial presents procedural information before the examination begins, so it tells you how to answer. There's a help feature if you get lost or confused. You also can mark items to go back. You can put your response. You can mark the item to go back and review if you want to. Remember, it's all multiple choice. And there is an administrator always available to help you. But I guess we all know the rule about our first thought on an item. Go with the first one, right? Everybody knows that, right? Because your second choice may be wrong. It's more likely to be wrong. Whatever your first choice is, stick with, unless you have good reason to change. Computerized administration advantages may mark items, as I mentioned, to go back and review. It gives you a tally of items completed. It provides time remaining, so you can see if there's a clock going on so you know where your time is. So if you think about it, you got 3 hours, right? That's 180 minutes, 150 questions. You don't have a lot of time to think about it, right? You got to go through it fairly quickly. It provides time for remaining to permit pacing self. It prevents common test-taking mistakes. It provides immediate feedback on your performance when you complete the test. Okay, Tony, is a computer-adapted model to give you all the items? It, as best I know it, they haven't gone, that's like a nursing exam. I don't know if the ECCC is doing that computer-adapted model, meaning that you either passed enough or you failed enough and it stops, right? Is that what you mean, Tony? It doesn't show you all the items. Is that correct, Tony? Yeah, something like that, okay. In general, does it take the full 3 hours to do the PEP? You know, I can only tell you what, for me, no. That doesn't mean anything. I mean, that's just me. So I don't really know. I've never asked people how long did they take. 180 minutes, you got to do 150 questions, right? So that's what somebody were able to do the math here. I've forgotten how to do it. Not really. So it's 30 minutes plus. So you have what? 1 minute, and then yeah, it's less than 1 minute per item. No, the other way around. So 180 minutes, 150 questions. So you have more than a minute. It would be like a minute and a quarter or something like that. Right, exactly. That's the ratio. Okay. 1.2 minutes. Yeah, that's what it is. So that's to read a question, identify the red herrings, identify the pertinent information, and make a decision. Some of the items are factoids. Okay, and I'll show you that in a moment. Some of the items require very detailed evaluation. So they're not, when they say they're equal in terms of their weight, I think some of the questions are harder, but that just depends on your knowledge base more than anything else. For me, there were a few things that I struggled with, but I got through. No problem. And if I can do it, anybody can do it, if they put their heart to it. Okay, so what do you get? Your feedback, you get the overall percentage correct score. So if you get something that says about 71%, you can pat yourself on the back and smile a lot and say you got through it. Performance in each 10 knowledge-based content, in other words, how many items you passed in that section. And that's interesting, but it's interesting in the sense that it might provide you with some feedback in an area of weakness. Okay. The report is forwarded to APA College or the Professional Psychology, and you get written confirmation of your scores. Okay. You answer all questions. It doesn't shut off if you passed or failed. Right. You have to answer all questions. That's the way they've set it up. To register to the PEP, okay, you have to meet these following criteria: doctoral degree in psychology, licensed health. The reason they put licensed health services in psychology is they're talking about people that see patients. Obviously, an industrial organizational psychologist shouldn't be taking such a test unless they're a retread. That's a different issue. Completion of the postdoctoral program in psychopharmacology with a minimum of 300 contact hours in neurosciences, pharmacology, psychopharmacology, physiology and pathophysiology, physical and laboratory assessment, and clinical pharmacotherapeutics. The thing that we've added in this last couple of years in Louisiana is the MRI imaging type things. That we think imagery is going to be more and more of a science in the future, and so we feel that the psychologists should be using those for diagnostic purposes. So if you were to ask me, can I order an MRI? Yeah, I can. One minute, 12 seconds. Thank you, Tony. Yes. Yes. They are well aware of this, so yes, they do. Alliant does meet the requirement. You won't have any trouble with Alliant. Okay. I may be interesting for people to know that the company who manages the PEP PES also manages the EPPP. That's interesting. I didn't know that, Tony. Thanks. Okay. Well, specs are, I'm not a big fan of specs. I like PETs a lot more, so I probably don't push for specs at all, but I'm more likely to do PETs. There's a new amyloid PET scan now being brought out for public use, but it's about a $3,000 procedure. It takes, essentially, it identifies the amount of amyloid plaque in your brain, and that's a good indicator. It has about 95% specificity, that type of thing. So it's very useful for determining if somebody has Alzheimer's disease. Now the problem with that is that there's no amyloid buster right now. There's nothing to stop the amyloid development. So you can, no insurance company is going to allow it. CMS has already ruled it out as a possible test. But that's what CMS did too initially with the PET scan. But I think in time it'll be pushed forward. But the real problem is it's kind of like you really want to know. I guess some people do. And I know there's data that says if you're told that you have Alzheimer's, the outcome isn't all that bad in terms of the complications, like the person might want to commit suicide or become clinically depressed. But again, if you're taking it early in life, when you're 50 years of age, and it's pointing towards the fact that you're developing amyloid plaque and you can't stop it, now you know you're going to die from this disease. It's a question of ethics a little bit for me because I have the same problem with Huntington's disease. when people want genetic testing. I guess you have the right to know, and if you want to do it, you'll have to pay for it. But I don't think it's always in our best interest to know unless we can do something about it. In this case, you cannot do anything about it, so it puts you in a helplessness state. That's the problem that I have with that. And if you look back at the Huntington's genetic testing, you'll find that many people couldn't tolerate the possibility of getting that disease, or even ALS. I have a patient that's dying from that now who knew she genetically had it, but never took the test because her father died the same way. So she knew that she had it, and sure enough, she does, but she's more advanced now. Yeah, you would get an early start on your bucket list, I guess is what you would do. And yeah, and it would probably kill your insurance for sure. Good idea. I mean, that's really probably where it's going to play out. Although you're supposed to not have any prior illness issues with insurance. Dessert first. Okay. Okay. So you meet these criteria. You got to pay your fee, which is the college gets $325 for the exam, and then Prometrics gets the other $200. Okay, so it's a $525 fee. I think if you fail, the fee drops down. You don't have to pay the full $325, but I think you still have to pay the $200 again. Hopefully, none of you will fail. Notification of approval is in approximately 30 days. They're actually getting a little faster than that, which is good. You schedule the exam within 120 days. They're trying to do a 90-day window these days, but a 90-day window meaning that you've been approved to take the test. Prometrics is saying they're going to administer that test within this 90-day window. Now, my understanding, and I've seen this happen a couple times, if you call Jan Chucho, if there's a crisis in your life, for some reason you need to extend that another 30 days or so, they're not going to deny you of that. They'll work with you. In the event of failure, this is what the APA's idea was, 90-day mandatory waiting period after your first failure, and your second failure you had to wait a year. Now, we in Louisiana didn't do that. We excluded that. We said they had to go through, I think it was, I want to say, you remember, Tony, it's in there somewhere. It's in our law. I want to say it was 6 months. You could test within 6 months or 3 months afterwards. It's much shorter time. I think we picked six months. The idea here is that, remember, they have 2 active tests, right? And if you test within the year 3 times, well, you're going to see one of those tests again. So that's why they're trying to do it that way. They're trying to create enough time between so that they can get the other test on before you take that third one. Otherwise, you will have a repeat test, and that would not be fair. But we set it up so that they could do that. Fortunately, that's never come to pass because everybody's passed in our state. I don't know about New Mexico. Anybody here from New Mexico?